admissions at the CCU, ICU, C8, B8, any admission reportable cases. Next day. And Saturday daytime meeting. Saturday CCU. Saturday ICU duty. Saturday C8. 8. B5, B8. Saturday night. Saturday night CCU. Saturday night CCU. Saturday night ICU. ICU, no admissions ICU. Okay. B8, B5.
Before B8, one admission, 13 years of stage 4 RBI on third line heart treatment, plus secondary HIV difficulty virus versus the super infection versus the protozoal infection, plus plus mild hyperkalemia, plus hyponatremia, secondary to the Diagnose. Then set this on the patient, non-RBI patient for the past 16 years. Currently on set the line they are range regionally, which was the change to part. But different variables then what is the name 2000 and the drug discontinuation for the 1 year and resumed 3 months back. Currently present is the volumes water in the area of 3 months with a shifted alternate current in the tension. After students having weight loss, they start test and proceed in next week. Otherwise, she has this TV treatment at the station at emergency. She was info. DQ was unreported in first event, and that later on and she was exhausted in weather science corrected. And during ICU admission, weather science are stable, and GP is 110 in 77.5, and spot rate 18, and only change shall be conjunctiva and extera. Leading influenza shall not be found in chest is clear. And various examination shall might be affected others. I was or the screening balance. There is no rush. And on stage she is conscious oriented to time person. And there is no time for neurology. With this, she was investigated in CSIM, which is an emergency. She leukocytosis with 13,000. Neutrophil is 72%, and lymphocyte is 20%. And hemoglobin is 13 grams per deciliter. Blood rate is in the normal range. And creatinine is resulting initiated 1.5 in the recent one. And product has sodium 1 plus 3 and 6. The exam was done times and first to show the test cells and the repeated one. Know about that vaccine. And show the abdominal ultrasound. There is a hypertrophic 7 by centimeter, 7 by 6 millimeter mass. Segment completely is suggestive of hemangioma. And currently on cerebral processing level and and the CPT and ORS levels. And currently pelvic flaps are stable. DRA is subsiding. And the plan is to do via the CD4 and modify stability.
Comments from the GI spec. What's the evidence for the GI TB?
Having the diarrhea, plus she has this complex of plus trophism next week.
So the B symptoms with the chronic diarrhea. We don't have a recent CD for this patient. Do we know her absolute lymphocyte count? Okay, okay. I think she's a candidate for the. She's taking the second line ART already. She's already on third line, and she has poor adherence.
Are you going to make a diagnosis of kidney crisis?
So just X-ray can be uploaded and displayed to the for the next presentations.
Yeah, we have said that if you have images, you can send it to me on Telegram. Good. Okay, thank you. Sunday daytime duty. I was on duty in the CCU. There were no reportable cases or incident reports at the CCU, ICU. No ICU reports, B8, B5. Okay. Last night's duty report, duty team. CCU, ICU. 5B8, C8. So were there no beds for the senior residents? Were there no beds or were there no admittable cases during the weekend? Three beds available at the C8 and the C8 D8 side. So no cases.
No patient.
There are patients, but I guess no patients with downward cup, or if there is any reason or issues that we can fix, let us know so that we can increase the turnover in the admissions. We had only one admission for about 4 days. Thank you. So we can move to our faculty update lecture. Today's faculty lecture would be with Professor Yeweyenhareg, and it will be on adrenal diseases in COVID era. Thank you.
Covet, the senior, the chief, senior, and Ara. Seriously.
Well, good morning, everyone, and welcome to today's update lecture. And my talk will be on adrenal disease in the COVID-19 era. Actually, the subject has never been discussed since the occurrence of COVID-19. So this will be your critical update on the topic. And at the end of this session, please focus on the learning objectives. The learning objectives of this session are 5. First, the major learning objective is to recognize advances in the topic of adrenal disease in the COVID-19. And the second is to describe the epidemiology and etiology of adrenal insufficiency in COVID-19 diseases, and to assess physiology and pathophysiology of hypothalamic pituitary adrenal axis in COVID-19 disease, and to practice the guidelines in diagnosis and treatment, strategies of adrenal insufficiency in Cushing Syndrome and this group, and also at the end to help and improve the care of this group of patients. So I have a small introduction session. The SARS-CoV-2 enters the host cell by binding the angiotensin converting enzyme 2 on the surface of the target cell, and the interaction is promoted by cleavage of the transmembrane spike glycoprotein, and mostly by the transmembrane protein serine, which is serine 2, which is TMPRSS2, and also by other co-receptors like capsin, BNL, and furin. So the expression of these two, SE2 and TMPRSS2 on the target cell is essential for the stable binding of SARS-CoV-2. And the lungs, as you all know, the lungs are the main targets of SARS-CoV-2 due to the abundant presence of this SEs and TMPRSS2. So as we all know, it is these two receptors are widely distributed throughout the human body, including the endocrine tissues such as pituitary, adrenal, thyroid, and pancreatic, and adipocytes. So endocrine tissues could therefore be a direct target for SARS-CoV-2. That's really very important. So it's a brief introduction, but this will take you throughout my presentation. So although we all know that glucocorticoids could play central role as immunosuppressant, And during the cytokine storm, they can have both stimulating and inhibitory effects on immune response, and depending on the timing of their administration and the circulating level. This is really very important, the timing of administration when we talk of acute versus chronic inflammatory process. So I will take you through the basic points first. And as you all know, the adrenal glands lie above the kidneys, and each gland has cortex and medulla. The medulla part produces catecholamines, which functions produce rapid response throughout the body in stress situations. And when we look at the adrenal cortex, it produces three main types of steroid hormones. The mineralocorticoids, such as aldosterone. Aldosterone is produced in zona glomerulosa. So whenever we look at the adrenal cortex, keep in mind JFR. So glomerulosa, fasciculata, and reticularis. So zona adrenal aldosterone produced in zona glomerulosa, and it helps in regulation of the blood pressure and electrolyte balance. And glucocorticoids like cortisone and cortisol are synthesized in zona fasciculata, and their main function includes regulation of metabolism and immune system suppression. And the zona reticularis produce androgen actually that are converted to fully functional sex hormones in different gonads and other target tissues. So here is an important schematic presentation of the hypothalamic pituitary adrenal axis. Here, physiological circadian information reach to the suprachiasmatic nucleus, and while stress stimulation reaches to CNS from brainstem and limbic system and brainstem. And all this stimulates the paraventricular nucleus. The paraventricular nucleus, here it produces as a response of this response on circadian information and stress stimulation, then the paraventricular nucleus releases corticotrophin-releasing hormone and AVP. This is antidiuretic hormone. So this travels through median eminence, and passes through portal circulation and stimulates the anterior pituitary cell and leads to release of adrenocorticotropic hormone. So adrenocorticotropic hormone acts on zona fasciculata and leads to release of cortisone and corticosterone. So this circulates and has a negative feedback on ACTH production as well as on CRH production. So this is a really very important physiological conditions, and we look at what is the body response in case of acute inflammation, chronic inflammation. So in acute inflammation leads to hypothalamic, acute inflammation leads to this release of cytokines like interleukin-1, interleukin-6, and this activates both the hypothalamus and the adrenal gland, the hypothalamus and the pituitary gland, and leads to production of ACTH, leads to production of cortisol by stimulating the adrenal fasciculata. So, cortisol is released into the circulation. This is a response of the acute inflammation. When you look at the chronic inflammation, so the body defends itself, and it will lead to protective adaptation mechanism. You can see during chronic inflammation, there will be a release of interleukin-6, TNF-alpha, and this can have an impact on CRH, on hypothalamus and pituitary, and the response is blunted. The response is blunted because this is a protective adaptation mechanism. We can see this in a patient with TB patient, COVID patient, and so on and so on. So this is an important point. The third one is exogenous glucocorticoids also has similar effects. And if it is high, it has a blunt effect on production of CRH and ACTH. So production of cortisol will go down. So when we look at epidemiology of adrenal insufficiency in general, the prevalence of primary adrenal insufficiency is estimated to be between 80 to 144 million. So actually this 144 million, it was reported by Professor Eystein Puspe from Western Norway, who is my supervisor when I did my subspecialty training and master in global health and master of philosophy in global health and research. So he is the one, he himself and his colleagues reported the prevalence of adrenal insufficiency of 144. So overall, autoimmunity being the most common and genetic causes are detected in younger individuals. Recently, the Iceland reported high prevalence of adrenal insufficiency, like 221 cases per 100,000. And the secondary prevalence of secondary adrenal insufficiency is estimated to between 150 to 200 million. So the other major cause of adrenal insufficiency is corticosteroid administration. So overall, increased mortality has been consistently reported in a young patient because of infection and acute adrenal insufficiency. So we have to keep this in mind. And when you look at the incidence of adrenal insufficiency, it's reported as 0.8 new cases per 100,000. And in Europe, they reported around 4.4 to 6.2 new cases per 100,000. The case fatality rate said to be of adrenal crisis said to be around 0.5 per 1,000. So when we talk of Addison's disease, it is actually the term used to describe primary adrenal insufficiency. And in Western countries, Addison disease, the cause of Addison disease is autoimmune disease, attributed about 85%. Among these, 60% of them are involved as part of autoimmune polyneuropathy. Tuberculosis was the most common cause in first half of 20th century. And so overall, when we look at the clinical picture of Addison's disease or adrenal insufficiency, to have the symptoms, more than 90% of the glands should be destroyed. So at the same time, if we are able to determine antibodies against steroid 21 hydroxylase, almost more than 85% of them are positive. So we did a collaborative research with University of Bergen, Institute of Medicine and Center for International. This is actually an international school which I did my my research. And I did also my fellowship training in Hookland University, in University of Bergen. So we did a very large study, a retrospective cohort study, and studied this prevalence of Addison disease from 1996 to 2004. And we found out the period prevalence of Addison's in Addis Ababa inhabitants are 30% per million. And the cause, we looked for the causes as well, and TB and HIV infection was the cause in up to 40%. So we have the data. So autoimmunity occurred in 4.8%, and in 21 cases, the cause of probable autoimmunity was entertained because when the sample didn't reveal autoantibodies, because these samples were taken several years after the diagnosis of this patient. And also as evidence, they do have 2 or more other autoimmune diseases. So the chance of probable autoimmunity, probably these are a group related with who has autoimmune diseases. We did another interesting study as part of this. We looked for adrenal failure in patients with pulmonary tuberculosis with and without HIV infection. To make things simpler, actually, we studied 87 consecutive patients with newly diagnosed smear-positive tuberculosis patients. It is a case control study. 44 of them were HIV positive, 43 were HIV negative, and we had 22 healthy controls. And we applied high-dose ACTH stimulation test and serum cortisol concentration at 60 minutes of less than 20 was considered as a cutoff point for adrenal insufficiency. We have also determined the assays of autoantibodies for this group of patients. And in this particular case control study, we found out that among 87 patients, 4 of the 87, that's 4.6 of patients were diagnosed to have adrenal insufficiency. And among these, 3 of 44, that is 6.8% were HIV positive. So keep this in mind. You can extrapolate this to the larger group of TB patients, the larger group of TB and HIV patients. So from this, actually, we found out it is rare. From this case control study, we found out it's rare. Adrenal insufficiency, rarely found in newly diagnosed active TB. There is another interesting, you see, I did this a decade and a half ago, this study a decade and a half ago, and now I really appreciated what I have stated in this particular paper. There were a significant higher basal and post-synaptic stimulation cortisol value in tuberculosis patients compared to control, indicating chronic stimulation of the adrenal cortex. And we recommend also synaptic testing should be reserved for those with low or normal basal cortisol. This is just a very interesting picture which really showed the basal and post-stimulation cortisol in active TB patients were significantly higher compared to the control group. This was the finding, explained with chronic stimulation of the adrenal cortex because of the infection. These are the cases of adrenal insufficiency, basal and post-cortisol. In all cases, the range of the basal cortisol between 12.5, 9.10, 19.8, and the basal, the post-stimulation between 10.5 to 19.1. So this will tell us something important information when we diagnose adrenal insufficiency in critically ill patients, in TB patient or septic patient, or even in COVID patients. So now let me take you to the relation of this adrenal insufficiency in COVID patients. I think you know that there was a COVID SARS outbreak in 2003, and they go back and analyze the data, and they found out that 32.9% of patients were diagnosed with hypocortisolism 3 months after their recovery. That's really interesting. The majority, actually around 83.3% of those who recovered were diagnosed with central hypocortisolism, and a significant margin of these patients, around 25% of them, experiences adrenal insufficiency and received hydrocortisone for 1 year and above. Okay, that is interesting. This is a retrospective information. And then when we look at adrenal insufficiency, this is interesting paper, adrenal insufficiency in coronavirus disease, infected patients with without pre-existing adrenal disease. They did a systematic literature review from 2019, December 2019 to May 23, 2021. And they found out in this systematic literature review, they found out 10 records of cross-sectional studies and 7 case reports. So from this, the age range, the age spectrum of the age range was between 22 to 96 years. And adrenal insufficiency was diagnosed based on laboratory assessment or radiological findings. And adrenal insufficiency prevalence ranged from 3.1% to as high as 64.3% in different studies. This magnitude is very high, really. So adrenal crisis is still common occurrence, and it is fatal in up to 6.3% of this group of patients. So there was a study from Lombardy, Italy. It was an observational case control study. They studied 279 patients, 212 of secondary adrenal and 61 of primary adrenal insufficiency. And they included 112 control group, and they looked at the clinical presentations of adrenal insufficiency in this group of patients and found out that gastrointestinal diseases are significantly higher in the control group compared to patients with adrenal insufficiency. And while fever is significantly higher in secondary adrenal insufficiency compared to the primary adrenal insufficiency in control group. Other than that, all the clinical symptoms like fever, cough, myalgia, fatigue, and conjunctivitis, dyspnea, and all are similar. There was no statistical significant difference in clinical symptoms. So hypothalamus, when we look at the hypothalamus in pituitary tissue, as I have stated it in the introduction part, this expresses SE2 and maybe a target for SARS-CoV-2, and it's the main associated hormone dysfunction after 3 months of recovery in the previous coronavirus disease. Central hypocortisolism in 39%, central hypothyroidism in 5%. Okay, so the hypothalamic and pituitary involvement in patients with SARS has been also demonstrated in autopsy findings. Here, pituitary, actually, the autopsy was done in 4 men and 1 woman patients, and they found hypophyseal, somatotrope, thyrotroph, and corticotroph producing cells were reduced in number and showed changes of suggestive of acute injuries like edema and neurological degeneration. Okay, these are the findings, pathological findings in the hypothalamus and pituitary area. So these pathological findings were supported with serological evidence and found out that low levels of circulating growth hormone, thyroid stimulating hormone, and adrenocorticotrophic hormone. So the other important information is about molecular mimicry. So SARS-CoV-1 and SARS-CoV-2 express specific amino acids sequence exhibiting a remarkable homology to acetate residue, and it has this really inactivate and destroys the endogenous ACTH, and it seems that this molecular mimicry knock out the human normal ACTH production. So overall, some evidences in some of points are limited because of insufficient literature results. And interestingly, we can really see some immunogenic epitopes expressed on coronavirus surface display significant homology level with mammalian ACTH, and some antibodies directed against the viral envelope may potentially destroy ACTH secreting cells. So thereby affecting the hypothalamic pituitary adrenal axis. Here, screen shares. Zoom. Is it okay? So this is just the one, this is just to show you the hypothalamic adrenal axis. Already I have gone through the physiological, pathophysiological conditions, but when it comes to the COVID-19, the SE2 and TEMP-RSS2 are expressed in hypothalamus. These receptors are expressed in hypothalamus, in the pituitary gland, and adrenal gland. This this illustration is just to show you this. And when we see the hypothalamus and the anterior, actually it is SE2 and temporal SE2 is highly expressed. Actually, it said it's highly expressed in hypothalamus and pituitary gland. So what will happen here is, if it's expressed, means damage to both the hypothalamic and pituitary and leads to no more production of cortisol. This is one mechanism. And on the other hand, and this leads to central hypothyroidism, central hypoadrenalism. And when it expresses on the adrenal gland, it leads to a direct destruction of the cortex and leads to no more production of cortisol. So this illustration are very quite informative. This is just to show you the summary of the pathophysiologic mechanism, how COVID-19 affects the adrenal, the cortisol production. So actually I've said a lot about the effect of SE receptors and TMPRSS2 receptors binding to the hypothalamic and pituitary. I have showed you this. And the second mechanism is there is a direct invasion to the adrenal gland. And the other one is molecular mimicry. Similar amino acid structure and antibodies produced against that destroys or stops the activity of the human normal SDH action. Another interesting point is TNF-alpha induced reduction in SDH release. And there is also the direct severe status of infection to the adrenal gland and hypothalamus pituitary dysfunction due to cytokine storms, you know, the cytokine storms, or this interleukin-1, interleukin-6, TNF-alpha, and all others destroys the hypothalamus and the pituitary. And the other point, which is not touched much, is about limited venous drainage, which has an effect on SDH production. So this is a summary. So one important point when talk of glucocorticoid in COVID patients, there we have to recognize 2 points. One is glucocorticoids induce adverse effect, especially when administered at high dose regimen. You all order dexamethasone of high dose for this group of patients. We have to keep in mind, we have to protect them, we have to be able to save them, but we have to administer this. And the most common adverse event includes signs related to hypercortisolism, like hypertension and hyperglycemia occurred in this group of patients because of this. One. The second important point is related to steroid administration. The second important point is abrupt discontinuation of glucocorticoid treatment, which leads to secondary adrenal insufficiency, even manifesting with adrenal crisis, So, so most of the time, the frequency of this adrenal insufficiency related to omission or discontinuation of glucocorticoid administration are related to 3 factors. One is with specific routes of administration, particularly intra-articular, or considering a cumulative dose of glucocorticoid, like more than 20 milligrams of prednisolone daily or equivalents, and also in the time of exposure greater than 3 weeks. So all these are a contributory factor for adrenal insufficiency. So when we look at adrenal gland, glucocorticoids play a pivotal role in priming the immune system as a consequence of infection or injuries. According to this point, patients with primary and secondary hypocortisolism are at increased risk for poor prognosis, particularly if we don't replace glucocorticoid in this group of patients, we know the fatal consequences. So we have to balance things together. So as we all know, this high frequency of lower respiratory tract infection in patients with primary adrenal insufficiency, that's the usual problem. And also, and actually such infection is more common. It's doubled in men and tripled in women in case of COVID patients. These are commonly due to acute adrenal insufficiency, especially it occurs in young individuals. So one important point here is there are several pivotal studies, and they found out the natural killer cell cytotoxicity, which has been essential, which has an essential role on antiviral immune defense, was impaired in primary adrenal insufficiency. So that is really very important. So as a consequence, patients are prone to develop infection and prone to develop adrenal insufficiency. In addition, adrenal insufficiency may result as a direct or immune-mediated adrenal injury after different acute infections. Most of the time for viral etiology, autoptic studies on SARS diseased patient had shown degeneration and necrosis of adrenal cortex, and SARS-CoV was identified in the adrenal gland as well, possibly confirming a direct cytopathic effect. They are identified in the messenger RNA in the adrenal gland. So they extrapolated the probability of direct cytopathic effect. So I think leukocytosis is a more common finding in patients with adrenal disease, but lymphopenia is common finding in patients with COVID. So it does not give you a clue. To look at the pathogenesis of lymphopenia in this clinical setting, there are several different factors like higher systemic inflammation and cytokine storms like interleukin-6, and the T-cell exhaustion and excess programmed days, cell days is there, and SARS-CoV-2 has a direct T-cell affection. So all this contributes. And in this setting, so overall, the diagnosis of this adrenal insufficiency really warrants awareness and recognize the hemodynamic and electrolyte abnormalities in this group of patients. So let me give you more evidence on from pathology findings. I will summarize it briefly. So actually, there was an interesting study from Western Brazil, Amazon, and they studied 28 diseased patients with SARS-CoV-2, and they did autopsy study. In this group of patients, actually they have signed informed consent from their legal representative, and also one pathologist studied and then two other pathologists revised, and there was a consensus agreement reached on this and the final diagnosis. And also what they did is they have measured serum cortisol in a sample which was frozen 1 to 2 days prior to the days of this patient. And in the sample result, none of the patient had serum cortisol values less than 10. So this is one important finding, and here is the data. Now, among 28 diseased patients, autopsy showed adrenal lesions in 12 of 28, that is 42.9% who died with severe COVID had adrenal diseases. Among these 7 cases, actually they identified both macroscopic and microscopic findings. 7 cases showed necrosis. Among 7 cases, 4 of them had ischemic necrosis. 4 cases showed cortical lipid degeneration. 2 showed hemorrhage. 1 specified focal adrenalitis, and 3 focal inflammation. And vascular thrombosis occurred in 1, and focal inflammation occurred in 4 of 28 patients. So the age range of this patient and everything, probably I'll leave you the references. So these are the histologic findings, interesting histology findings. So this is histology findings from right adrenal gland with extensive areas of hemorrhage, And here also you can see extensive areas of hemorrhage and thrombins and fibrin and hemorrhagic necrosis here, adrenalitis here, and adrenal carcinoma, malignant infiltration cells. And here you can see diffuse and severe cortical vacuolization with both form macro and microvascular vacuolization. So in conclusion, adrenal lesions were frequently observed in patients with who died with severe COVID, up to 46%. I don't know how many patients we have lost, and this really an alarming figure. So the detected lesions are necrosis, cortical lipid degeneration, hemorrhage, and focal inflammation. So, so there is one major limitation of this study, which I have noticed. And in this particular analysis, they didn't identify the RNAs in the adrenal gland. So that was the limitation, but they didn't identify other causes to attribute to the death of these patients. So two questions related to our patient with adrenal insufficiency at increased risk of COVID-19. We look, the first question, risk of adrenal crisis during acute illness is there. Already have given us the background information. They develop potential life-threatening adrenal crisis. So we have to increase dose of glucocorticoid replacement. So adrenal crisis occurs both in primary and secondary adrenal insufficiency. The other, is there any increased risk of infection in adrenal insufficiency? Say yes, because already have given you the information earlier. And so therefore patient with primary adrenal insufficiency can be assumed to be an increased risk of infection with COVID-19. That's the conclusion. Some says no, but we have to favor what's good for our patients. So how do you diagnose adrenal insufficiency in a patient with COVID? So there is a high dose acetate stimulation test, which we call it synaptin stimulation test, remains again the gold standard test. And the peak cortisol level of below 18 at 30 to 60 minutes, indicating of adrenal insufficiency. Actually, this is a test which is easy to perform and safe. I did it for the research purpose. I already have showed you part of the data. And one other important point here is, are we going to do synaptin stimulation test here? It's very difficult. First of all, the drug requires a cold chain. The synaptin requires cold chain. It's very expensive. That's why we recommend, from our study, we recommended to use it for those individuals with low cortisol or normal cortisol values. So do you have any other solution? Yes, we can use the definition given for critical illness related corticosteroid insufficiency, that is plasma cortisol of less than 10. Okay, that's really very important, less than 10. Previously we used 15. Some physicians also still consider 15 microgram of plasma cortisol. And there is also increased cortisol of less than 19. That is, you interpret this if you are able to do synaptin stimulation test. Otherwise, for our circumstance, we can use the serum plasma cortisol of less than 10. So as a diagnostic criteria, and European, when you look at the treatment, European guideline for management of acute adrenal insufficiency in COVID-19 pandemics, there are sick day rule 1. In sick day rule 1, administer 20 milligram of hydrocortisone orally every 6 hours in case of signs and symptoms of suggest for COVID-19. And there is sick day rule 2, and when there is clinical deterioration, you advise a patient to inject himself 100 milligram of hydrocortisone intramuscularly, or increase the dose of prednisolone from 7.5 to 10 milligram BID. That is an option. And then refer the patient to the hospital or admit to ICU for management. Then after admission, then you go for 100 milligram of hydrocortisone start, following 200 milligram over 24 hours can be given intermittently or IV in this particular patient. Fluorocortisone replacement should be continued until the habitual dose of asymptomatic or mild cases. When hydrocortisone replacement is higher than 50, then you stop the fluorocortisone and reinstitute when after stabilization hospitalization. So education is very important. So we have to ensure that all patients and family members are educated in sick day rules, increase the usual glucocorticoid. In part of education, you have to include to increase their usual glucocorticoid replacement dosing during illnesses. You have to educate them how to self-inject hydrocortisone. These are really very important, and educate them about stringent distance and social working, and tell them to work either at home or work with conditions that allow very stringent social distancing. So what's really important is telemedicine may be a tool for improving management of this group of patients. So I think I have a few more slides to tell you about Cushing syndrome, because this is really very important. So Cushing syndrome, it is an observed in uncontrolled Cushing syndrome, leads to what? Hypercortisolism may increase the cardiometabolic risk, induce thrombosis, immunosuppression, and systemic inflammation. So these things also can happen because of simultaneous exogenous administration of cortisol. So the main effects of high cortisol level in Cushing syndrome patient are leukocytosis, neutrophilia, lymphocytopenia, and monocytopenia. Although the overall number of neutrophils increase, their ability to migrate and damage tissue and their response to other things are impaired, like inflammatory stimuli such as interleukin-8, interleukin, tumor necrosis factor, interleukin-1B are impaired, okay? Impaired, even if there is leukocytosis, take care. Hypercortisolism also affects activation of natural killer cells and also affects the complement system. So here, there is this is an interesting table which can summarize things related to comorbidities related to Cushing and their the effects of high cortisol and possible risks in COVID-19 patients. So the immune system affected is leukocytosis and neutrophilia, decreased B lymphocytes and T lymphocytes, and also decreased neutrophil response, increased pro-inflammatory cytokines. So all this has a possible risk on immune system modification and increases the risk of viral infection. Okay, this is the association. Obesity is a very good media, and it increases interleukin-1, interleukin-6, and TNF-alpha, increased number of adipocytes. Also, this induces pro-inflammatory state of obesity, leading to ARDS in case of COVID patients. Okay, the other type 2 diabetes, worsening of hyperglycemia, particularly if they are in DPP-4 inhibitors. DPP-4 is also acts as a receptor for SARS-CoV-2. So it helps to aggravate the circumstance. Hypercoagulability, increased factor 5, fibrinogen, Vorwin-Brand factor, decreased fibrinolysis, and all worsening and early in a patient with COVID, it worsens the hypercoagulable state. Arterial hypertension, the same, and bone metabolism, increased osteoporosis, osteopenia, and bone fracture. So actually this group of COVID patients can have also bone fracture. I don't know how many of them face this problem, I'm not sure. Neuropsychiatric disorder, you know, major depression, effect of hypercortisolism leads to major depression and anxiety, and then this leads to worsening of mental health in a COVID patient. So cortisol excess and its related comorbidities are like diabetes, hypertension, should be managed as best as possible. And it should be noted that respiratory tract symptoms may be a consequence of opportunistic infection, so advisable to put them on prophylaxis, trimethoprim, sulfamethoxazole. So when diagnosis and when you look at diagnosis and treatment, we cannot go through all these heavy screening method, probably we can do overnight dexamethasone suppression test or 24 hours urine cortisol, and so on and so on. So more emphasis must be given to crucial clinical markers of Cushing, and in questionable cases, we advise a wait and see approach. This is the approach, a wait and see approach. So you have to delay the investigations if the patients are not in critical state. That is recommended by several endocrinologists. And when there is a patient with moderate to severe clinical diseases, they have to be investigated and managed urgently and to avoid poor prognosis. So in patients with Cushing syndrome, cortisol normalization is one of the most important therapeutic targets. Surgical or medical treatments are required to control Cushing. And so as I have mentioned it earlier, you can do 24 hours urine-free cortisol and so on. Surgery should be considered only for severe cases, only for severe cases. So we advise medical management may be more appropriate for others. So steroidogenesis inhibitors such as ketoconazole are the first line therapy for Cushing syndrome. Ketoconazole might, as you know, ketoconazole might cause acute liver toxicity. So liver function test determinations frequently in the first few weeks and then every 3 to 6 months is very important. Like drugs like mifepristone, glucocorticoid receptor antagonist should be handled for those individuals with uncontrolled hypertension, hyperglycemia, and psychotic symptoms. So one more advice here is really for this, or when put them on this medical treatment, they can have high regimen is really indicated. Block and replace regimen is indicated. So patient with Cushing syndrome, I think all these patients with complications like hyperglycemia, dyslipidemia, and hypertension and hypercoagulable state can be managed with glucose lowering agent, antihypertensive, and antithrombosis. So almost I'm finishing. I have only summary slides. Here is a summary of my presentation. Prevalence of adrenal insufficiency ranged in a COVID patient ranged from 3.1 to 64.3%. And here is the mechanism of action in hypothalamus and pituitary gland. Keep in mind that there is immune-mediated damage of the hypothalamus, pituitary gland, and impaired release of CRH, ACTH, and molecular mimicry to ACTH should be considered. Adrenal glands like ischemic necrosis, hemorrhage, cortical lipid degeneration, and focal inflammation should be considered. And so COVID-19 causes, affects adrenal function and cause both primary and secondary adrenal insufficiency and adrenal crisis. There should be high index of suspicion for adrenal insufficiency patients with COVID-19 with hyponatremia and hypotension. So routine use of glucocorticoid in patients with COVID-19 is controversial, but in acute phase, but after a few days, it's obviously, I have showed you the effect of chronic inflammation, so there is a place for high-dose glucocorticoids. Adrenal insufficiency in COVID patient might be transient, but actually it warrants follow-up. I have showed you the study. So when mild Cushing syndrome, the investigation should be deferred according to a wait and see approach. Patients with moderate to severe clinical disease must be investigated and managed urgently. These are my references. Really, I thank you very much for listening to my lecture and for your patience. Thank you very much. Now the floor is open for comments and questions. I'm happy to hear. Actually, I kept my time.
Yeah, you are on time. Thank you very much for updating us on adrenal diseases related to COVID-19. So you have highlighted how the clinically relevant situation of fatigue post-COVID-19 is explained in this category of patients. It is a common encounter to see most of patients who have COVID-19 to be having an ongoing fatigue. So part of the explanation is what you have presented in the pathophysiology and its effects. And the management that you have highlighted is also the way to go in managing these patients after COVID-19. The Cushing management, the medical treatment, I think it is just as a bridge. One of the slides mentioned ketoconazole is the first line of treatment. I want just reasons to be clear about it.
Yeah, regarding ketoconazole, actually I practice this in a patient who has Cushing syndrome, who are inoperable, and so on and so on. What I usually do is I usually go for block therapy. I usually give them ketoconazole or 400 milligram BID to start with, even I can go up to TID. And then meanwhile, where they're instead of hypercortisolism, I push them with prednisolone. That is a block therapy. So you prevent sudden occurrence of adrenal insufficiency. Actually, these patients are prone to develop sudden onset of adrenal insufficiency and they die of adrenal crisis. So you have to be expert enough to go for block therapy. That's my advice for endocrinologists. Actually, fellows will follow and endocrinologists can do that. Otherwise, it's a life-threatening circumstance. If you are confident enough, you can do it. I usually do that. I usually do block therapy and giving ketoconazole at one wing, monitoring their liver function test regularly, and at the same time giving them prednisolone, watching them very, very closely, this patient, and gradually you will discontinue ketoconazole, you will come up and will maintain them with prednisolone. That's very successful, actually. That's what I mean, okay? Is it clear now?
Yes, it is.
Great, okay. And the other drug, should we have to delay it for uncontrolled mifepristone? Actually, it's not available here, but if it is available, probably we should not embark to initiate this drug for this group of Cushing patients. We have to hold it for those individuals with uncontrolled hypertension, hyperglycemia, and also psychotic manifestation. Okay, any other comment, questions, please? Okay, Doctor.
Thank you.
As usual.
So my issue is, the prevalence is about up to 46% in severe COVID case.
Pathological evidence.
And this group of patients are getting dexamethasone for the standard treatment of severe COVID, not for adrenal insufficiency. So, despite that, if we have this number, what's your comment on dosing or something about is that dexamethasone we are giving is not helping it, or do we adjust the dose? I don't know.
Actually, that the point of chronic inflammation, there is a blunt response of CRH and ST. If acute inflammation means the inflammatory process up to 1 week, actually. That's the storm starts after 5 days and so on and so on. I don't know. So what will happen is there is a chronic stimulation. When you give high-dose hydrocortisone, what will happen is it will saturate the body and knock out the CRH and ST. That's the purpose. So when you discontinue this, the chance of going to adrenal insufficiency is quite high. That is the implication. So I do not mean that we should not give high dose. We will give, but keep an eye for those individuals who are at risk probably will taper it gradually. That will be really very important. So Dr. Abdul has raised the issue of fatigue, weakness, and everything. Actually, this group of patients really do have some component of adrenal insufficiency. Adrenal insufficiency. To me, I really advise, if we have the access to determine serum cortisol, that is a practical point which I advise all my residents and fellows. If you have the access to determine serum cortisol, draw blood before you rush and give high dose dexamethasone, draw blood, okay? Keep centrifuge it, keep it in the refrigerator under -20, and then go ahead and treat your patient with a high dose dexamethasone suppression test. In the morning, you can send the serum cortisol to the lab and you can get it back within 2 to 3 days. So if the serum cortisol value is between 10 and 15, I assure you that your patient is a candidate for adrenal insufficiency. 10 to 15 is a candidate for adrenal insufficiency. If the cortisol value is above that, a candidate is not at risk for adrenal insufficiency. That's what I have learned throughout my experience. So that's my recommendation. So if it is of between 10 to 15, you should not stop the cortisone suddenly, high dose dexamethasone administration suddenly. You decrease the dose gradually and follow your patient, okay? You can put him on maintenance dose. That's the practical point which fellows and residents should follow. That's a practical point, actually. Did you get the point?
Yes. Yes.
Okay, any more questions, comments? So here, thank you very much for listening and for your active participation too. Actually, you'll get the slides. So Dr. Hannibal, you'll forward the slides to the residents. So they'll learn a lot.